Welcome to the Irish Practice Nurses Association online education series for general practice nurses. My name is Teresa Lowry-Lanin. I'm a member of the Carlow branch of the IPNA, and today we are going to talk about otitis media, looking at the etiology, symptoms, diagnosis and treatments. Otitis media is the term for a group of infective and inflammatory conditions affecting the middle ear, with a variety of subtypes differing in presentation, associated complications and treatment. Acute otitis media, referred to as AOM, is an acute suppurative infection marked by the presence of infected middle ear fluid and inflammation of the mucosal lining of the middle ear. AOM can be caused by either bacteria or viruses. Streptococcus pneumonia, Haemophilus influenzae, and Moraxella catarrhalis are the main bacterial causes of the infection. Viruses that cause AOM include the RSV virus, rhinovirus, influenza, and adenovirus. Acute otitis media affects about 11% of the global population annually. It occurs more often in children than in adults and is one of the most common pediatric infections antibiotics are prescribed for. Half of cases involve children less than 5 years of age, and more than 75% of episodes occur in children under 10 years of age. Most cases occur in young children aged 6 months to 24 months. The main symptoms of acute otitis media include severe earache, a high temperature of 38 degrees or above, and slight deafness. Other symptoms include tenderness of the skin above the ear, purulent discharge from the ear, loss of balance, irritability, vomiting, lethargy, and diarrhea in infants. Since an episode of otitis media is usually precipitated by an upper respiratory tract infection, there are often accompanying symptoms like cough and rhinorrhea. A feeling of fullness in the ear may occur. Other symptoms in young children include pulling, tugging, or rubbing their ear, poor feeding, restlessness at night, unresponsiveness to quiet sounds, or other signs of hearing difficulties or being inattentive. Complications of acute otitis media include perforation of the eardrum, mastoiditis, and more rarely, intracranial complications such as bacterial meningitis, brain abscess, or dural sinus thrombosis. It is important to make an accurate diagnosis of acute otitis media to avoid overtreatment with inappropriate antibiotic therapy. Ear infections will often resolve on their own without antibiotic treatment. Taking antibiotics when they are not necessary can be harmful and may lead to unwanted side effects like diarrhea, rashes, nausea, and stomach pain. Symptoms alone are not sufficient to diagnose acute otitis media. Evaluation of the patient's clinical presentation and careful otoscopic examination are important in making the correct diagnosis. To confirm a diagnosis of AOM, middle ear effusion and inflammation of the eardrum must be identified. Signs include fullness, bulging, cloudiness, and redness of the eardrum. It is important to differentiate between acute otitis media and otitis media with effusion, often shortened to OME, as antibiotics are not recommended for OME. Bulging of the tympanic membrane suggests AOM rather than OME. Otitis media with effusion, often referred to as glue ear, is the presence of non-infectious fluid in the middle ear for more than 3 months. It is not typically associated with symptoms, but occasionally a feeling of fullness is described. Otitis media with effusion frequently occurs following AOM and may be related to upper viral respiratory tract infections and irritants such as smoke or allergies. Sometimes the fluid becomes infected, leading to AOM. After an episode of AOM has been treated or resolved on its own, fluid may remain in the middle ear and take longer than a month to resolve. Otitis media with effusion rarely develops in adults. When it does, it is more likely to signify underlying eustachian tube dysfunction rather than preceding AOM. It usually follows a significant upper respiratory tract infection such as sinusitis. Other possible underlying factors include severe nasal septal deviation, large tonsils and adenoids, nasopharyngeal tumor, head and neck radiotherapy, and radical head and neck surgery. Middle ear fluid in adults should be treated as suspicious, particularly if it is unilateral. Chronic suppurative otitis media, often referred to as CSOM, is a chronic inflammation of the middle ear and mastoid cavity. It is characterized by a discharge from the middle ear through a perforated tympanic membrane for at least 6 weeks. It may be a complication of acute otitis media. Pain is rarely present. Inflammation produces mucosal ulceration and breakdown of the epithelial lining. Granuloma formation can develop into polyps in the middle ear. Chronic suppuration can occur with or without cholesteatoma, and the clinical history of both conditions can be very similar. Cholesteatoma is an abnormal accumulation of squamous epithelium, usually found in the middle ear cavity and mastoid process of the temporal bone. Granulation tissue and ear discharge are often associated with secondary infection of the desquamating epithelium. All three types of otitis media may be associated with hearing loss. Children with recurrent episodes of acute otitis media and those with OME or CSOM have higher risks of developing conductive and sensorineural hearing loss. This is more common in males than females. Conductive hearing loss from otitis media can have a serious effect on speech and language development in children. The etiology of otitis media is multifactorial and relates to anatomical variations, pathophysiology including the interaction between microbial agents and host immune response, and cell biology of the middle ear cleft and nasopharynx. Upper respiratory tract infections, such as a common cold, can lead to mucosal congestion in the eustachian tube and nasopharynx. The resultant congestion prevents normal eustachian tube function and pressure regulation is altered within the middle ear. The mucus can't drain properly, making it easier for an infection to spread to the middle ear. Younger children are vulnerable to middle ear infections due to a smaller eustachian tube and larger adenoids than adults. Children who are born prematurely also have a higher risk of developing complications. Certain conditions, such as a cleft palate and Down syndrome, increase the risk of developing middle ear infections. While it is not possible to prevent middle ear infections, there are a number of ways to reduce the risk in children. Acute otitis media is less common in breastfed than formula-fed infants, and greater protection is associated with exclusive breastfeeding for the first 6 months of life. Ensuring children are up to date with vaccines, especially the PCV vaccine and DTaP, IPV and Hib vaccines in early infancy decreases the risk of acute otitis media in healthy infants. PCV, however, has not been shown to decrease the risk for high-risk infants or older children who have previously experienced otitis media. Influenza vaccination in children has been shown to reduce rates of AOM by up to 4%. Environmental exposure to tobacco smoke, feeding children while lying on their back, and the use of pacifiers are all associated with increased risk of developing otitis media in children and they should be avoided. Minimizing contact with other children who are unwell may also help reduce a child's chances of catching an infection that could lead to a middle ear infection. Most cases of otitis media resolve within a few days. However, it is important to seek medical attention if symptoms show no sign of improvement after 2 or 3 days, especially if there is a lot of pain, discharge, pus or fluid coming from the ear, or if there is an underlying health condition such as cystic fibrosis. People with congenital heart disease, lung, liver, neuromuscular conditions, and those who are immunosuppressed are also at higher risk of developing serious complications. NSAIDs, for example ibuprofen or paracetamol, can be used for symptomatic relief. Aspirin, however, should not be considered or given to children under 16 years of age. Decongestants or antihistamines may reduce swelling of the mucous membranes in the nose and back of the throat, keep the eustachian tubes clear, and allow mucus to drain from the middle ear. However, research has shown that antihistamines and decongestants do not help prevent ear infections. A warm compress over the affected ear may help to reduce the pain. Most children over 6 months of age who develop acute otitis media do not benefit from antibiotic therapy. Antimicrobials are not routinely used to treat middle ear infections, although they may occasionally be prescribed if symptoms persist or are particularly severe. Many cases of otitis media are viral in nature, and the illness resolves over 4 days in up to 80% of cases without antibiotics. Watchful waiting is the preferred approach for children over 6 months with non-severe acute otitis media. A no or delayed antibiotic strategy should always be considered. However, if a bacterial infection is likely and antibiotics are clinically indicated, amoxicillin is the preferred choice with a recommended duration of 5 days. If allergic to penicillin, clarithromycin is recommended for a duration of 5 days. Children with otorrhea or less than 2 years of age with bilateral acute otitis media achieve greater benefit but are still eligible for delayed prescribing. So as already stated, amoxicillin is the preferred antibiotic, recommended duration being 5 days. The image on the left shows the normal dose according to the age of the child. So for instance, a child less than 1 year of age, the normal dose would be 125 milligrams 3 times a day. For a 1 to 4-year-old, it would be 250 milligrams 3 times a day. 5 to 11-year-old, 500 milligrams 3 times a day. Or for 12 to 17, 500 milligrams 3 times a day. On the right, then you can see that clarithromycin is the drug of choice if the patient is allergic to penicillin, and again the recommended duration being 5 days. And again the chart shows the approximate age of the child and the dose based on the weight of the child. For children with recurrent severe otitis media, tympanostomy tubes, better known as grommets, may be inserted to help drain the fluid. Removal of the adenoids and tonsils may help if they are blocking the entrance to the eustachian tube. Antibiotics, steroids, antihistamines and decongestants are not recommended to treat otitis media with effusion, and if present for 12 weeks or more, OME requires referral to ENT. Let's now look at otitis media in adults. The signs and symptoms of AOM in adults are very similar to those in childhood, with hearing loss, otalgia, and fever. In adolescents and adults, otalgia is a more common presenting symptom than in children under the age of 2. Otalgia may occur without fever or hearing loss and may be the only presenting feature. Analgesics such as ibuprofen or paracetamol are used for symptomatic relief. Nasal and oral steroids are sometimes indicated for persistent AOM and a history of allergies. For most adults, a no antibiotic or a delayed antibiotic prescribing strategy should be considered. Antibiotic therapy, when indicated, is a 5-day course of amoxicillin, or for those allergic to penicillin, a 5-day course of clarithromycin or erythromycin following the adult dosage guidelines. An immediate antibiotic prescription should be issued to patients who are systemically unwell, those at high risk of complications because of significant heart, lung, kidney, liver, or neuromuscular disease, or patients who are immunocompromised, and to those whose symptoms have lasted for 4 days or more and are not improving. Differential diagnosis for AOM in adults is essentially the same as in children. In adults, temporomandibular joint dysfunction and associated differential diagnoses should be considered. These can include angina and acute coronary syndromes, giant cell arthritis, dental problems, trigeminal neuralgia, migraine, trauma, herpes zoster, and ENT disorders. Cultures may be carried out if chronic perforation is suspected, and CT or MRI scanning may be required to exclude complications. Tympanocentesis may be indicated where local or systemic complications have developed and in patients who are immunocompromised. Patients with acute complications of AOM, such as meningitis, mastoiditis, facial nerve paralysis, or who are systemically very unwell, should be admitted for assessment. Routine referral to an ENT specialist is required if the patient has a craniofacial abnormality or has recurrent episodes which are distressing or associated with complications. Urgent referral to an ENT specialist is required if nasopharyngeal cancer is suspected in adults, especially in the presence of persistent symptoms not responding to treatment, persistent cervical lymphadenopathy, and unilateral epistaxis. As with children, complications in adults include tympanic membrane perforation, OME, and CSOM. Severe infratemporal complications in adults include mastoiditis, acute labyrinthitis, petrositis, facial palsy, and acute necrotic otitis. Intracranial complications include meningitis, encephalitis, otitic hydrocephalus, sigmoid sinus thrombosis, and brain abscesses. Patients with uncomplicated AOM are usually treated in primary care, and the prognosis for most people is very good. While seen frequently in children, AOM is less common in adults, and the incidence is approximately 0.25% per annum. Early diagnosis and prompt treatment decreases the risk of complications occurring and resulting in better patient outcomes. With the exception of those with risk factors and complications, most middle ear infections in adults completely resolve in a couple of days. And this is a list of the references that were used in the production of this presentation. I hope you enjoyed this presentation on Otitis Media, which is part of an online education series for general practice nurses produced by the Irish Practice Nurses Association. I'm Teresa Lowry-Lenin, and I'm a member of the Carlow branch of the IPNA. Thank you for watching and listening.